welcome. Good afternoon. Glad you're here with me. And we are going to talk today about rural pharmacy scholars. And this is all part of UNC's Community Engagement Week, which I'm thrilled to be participating in. Community engagement has always been near and dear to my heart over the 30 years of pharmacy practice that I have completed, which is hard to believe. So I do have some slides I'm going to share with you today, but welcome. I'm always happy to talk about this work and what brought me to it. The title is Rural Pharmacy Scholars, Offering a Graduate Certificate in Rural Pharmacy Health as a Strategy Towards Healthcare Workforce Development. And so I'm going to tell you a little bit about our background in this work with UNC Eshelman School of Pharmacy, a little bit of what drew me to it as a faculty member. I am someone who came to academia a little later in terms of my pathway. I've lived and worked in Western North Carolina for the bulk of my pharmacy career. These mountains and rural communities have always been very precious to me. I grew up in a very rural place in Eastern North Carolina. I don't even really call it a town, I call it a crossroads. Plainview community, which is near Dunn, North Carolina, or Spivey's Corners. Some people have heard of those places. So I'm just going to talk with you today about how this program was implemented, our ongoing efforts to establish it, sustain it, and continue the growth of it as it relates to where we have emphasis right now, which is mostly Western North Carolina, some of our hopes for Eastern North Carolina. And then talk about some of the benefits, challenges, maybe we'll call those challenges and opportunities associated with engaging key stakeholders in our community and folks that we want to work with to train our learners to really give them that love for rural place and rural patients. So this is just, a really easy background to talk about where did this happen? Where are you? Stephanie Kaiser, that's my name. I'm Stephanie Kaiser. I'm a professor of the practice working with UNC Asheville School of Pharmacy. Our Asheville campus, a remote campus, actually started in 2011. A lot of our UNC colleagues aren't aware of that, but we have had the campus here where we have had UNC Eshelman pharmacy students physically here with a remote connection since then, and the classes are connected between Chapel Hill and Asheville, with first year being pretty heavily delivered from the Chapel Hill campus, but those second, third, and fourth years, we as faculty are also teaching. So our learners are used to this digital learning space. In 2014, they lifted up and got the approval through the graduate school to offer the certificate in rural pharmacy health. And that was when I joined the faculty, was in December of 2014. After working with Mission Health System for 20 years, working a lot with underserved and rural populations, working in the disease management space, I saw it as a great opportunity to say, how do we influence training and encourage learners and future pharmacists to also have an interest in this patient population? We realized that we also needed to create some postgraduate experiences. So that PGY2, that's postgraduate year 2 pharmacy residency programs. So again, those residents were put into play in the community to help develop new practice sites. Because one of the things we recognize is if we're going to put learners into these regions and communities and give them a love for the community, we also need to be making contribution to job development, for those folks. Pharmacy is an evolving career. We are really beginning to transition from being in that traditional community pharmacy space, although it is very much still our backbone of how we connect with the community, but being more engaged with rural primary care practice and helping support family practitioners, and then also being a part of specialty care and helping extend that care. In 2017, we had our first rural pharmacy scholars to graduate, and I'll tell you later about where our scholars are currently and how we're trying to keep up with them and what they're doing. And then as of the class of 2025, which is the class that's recently recruited and the class that I recently recruited for rural scholars, we will have 46 rural scholars since the inception of the program, which I think it's pretty impressive because we only offer this currently on our campus here in Asheville. So it's kind of a smaller student cohort to begin with, and to have almost 50 of them, I think is really wonderful. So a little bit about the why. Why did the School of Pharmacy even care about having something that's got more of a rural emphasis, and specifically why focus in Western North Carolina? So this is just a nice map. I use it all the time. I love the NC Rural Center's way of defining rurality in the state of North Carolina because it's very clean and crisp and makes sense to me. There's a lot of debate out there on how you establish rural definition. So I'm sure someone would argue 25 ways with me about this map. But for purposes of a visual, it's very nice. All of the counties that are shaded in green are classified as rural counties by the NC Rural Center. Those that are in that dark blue are suburban counties, which to me makes sense. I live in Buncombe County, and the city of Asheville, which is 80,000 people, is right at the center of Buncombe. But the population density changes dramatically once you get outside of the city of Asheville. So it's a county of 250,000 people, and out where I live, it's farmland. I'm still in Buncombe County, but I can be in downtown Asheville in 15, 20 minutes. And then those orange counties, and if you're North Carolinian, you're not surprised by this, those are our urban centers. So it's Charlotte, it's Raleigh, Wilmington on the coast, it's Greensboro, High Point, Durham. So this just gives you a sense that if you didn't recognize it and you don't go out of the Raleigh, Durham, Chapel Hill area very much, if you drive around our state, we have a significant number of rural residents. Almost 2 million people in North Carolina live in rural communities, and that means that they are influenced significantly as it relates to healthcare access. So where I am sitting right now, we are concentrating mainly on these Western North Carolina counties. But I know many of you are probably looking to the east and going, but Stephanie, look at all those counties in the east and what's happening there. So we'll talk a little more about what our goals are for the future. But we started here in Western North Carolina because we had a lot of assets and resources in terms of commitment. We've got Mission Health that's here. We have MAHEC, Mountain Area Health Education Center. Those were big commitments that we could very easily stand up the campus and the initiative out here. So we want to replicate. This is kind of what I call the so what slide. I share this with students. It's the why do we get sent all over North Carolina when we're training? Why should we care about rural places and rural healthcare? And this is the so what. So when you're looking at this map, which comes out of the Department of Health and Human Services, we still have significant issues as it relates to health provider shortages in our state. So our population continues to grow, but unfortunately, especially in our rural communities, and in some cases, some of our more urban, suburban counties here, our growth of population is far exceeding our number of primary care physicians, our mental health services, our behavioral health services, and dental health services. Now, what you won't see are pharmacists on here, and that's because we're not really classified as providers, for this mapping purpose. But what I can tell you is in all but I think 2 counties of North Carolina, there is a pharmacy located in that county. And so what I say to people is there's a tremendous opportunity for pharmacists to be partnering with other healthcare providers to extend care, enhance care, and actually try to bridge some of those healthcare disparity gaps. So another thing that I like to talk about as I talk about the background to rural scholars is, and because this is at the heart of what we talk about exceedingly and what I teach and what they engage with their preceptors and communities around, is around social determinants of health. And this has become very normal to talk about this now. I have seen this grow exponentially since I joined the school. When I joined the school back in 2014, I was one of the few professors who actually talked a lot about social determinants of health in my pharmacy coursework. Now it's very commonplace. It's beginning to show up in a lot of our curriculum, but I still pull this out, and I always joke with my rural scholars that, like, okay, you have to get your mandatory social determinants of health tattoo because we talk about it in every class. But it's really talking about the fact that policies and programs drive a lot of things as it relates to health factors, And then ultimately that's contributing to health outcomes. And I like Robert Wood Johnson and County Health Rankings roadmaps. Their definition of length of life and quality of life is how we look at health outcomes. And the big emphasis is we know we're going to train exceptional, brilliant pharmacists to come out of our program. And what I want them to understand is even when they show up as smart as they are and do everything as well as I know they do it, we ultimately only contribute about 20% to somebody's overall health outcomes. So really understanding health behaviors, social and economic factors, and physical environment doesn't mean we solve all those problems as pharmacists, but as community members and civically minded healthcare providers, we can engage in our communities to influence improvement in these other areas. We can also broaden our knowledge of resources in terms of how we refer patients and navigate them. And so I want them to show up 100% every day and do a great job. And I also want them to be mindful of where are the food pantries in the community and who are the resources that I can refer my patients to at the end of the day. Place matters. Where you were born largely influences your health outcomes. So how are we improving health outcomes in communities where we know there are already health disparities? So that's a lot about the background of the why, but I think it's very helpful to understand how we've constructed certain parts of the certificate. And so this is just a summary. 80 of our North Carolina counties are classified as rural. Rural counties have health provider shortage areas. They continue to have them. And rural residents often do not have equitable, I'll say equitable, healthcare access, which is contributing to them experiencing poor health outcomes. There's lots of data out there that supports those three comments. So our Asheville campus and our Rural Health Initiative, our goal was to increase the number of pharmacy graduates who live and practice in rural and small communities or serve those patient populations, to advance pharmacy practice, to be supportive of that extending of primary care, and contribute to improving health outcomes. So that's kind of our driving banner, why are we doing this work? So on this slide, I just want to go into a little bit of the nuts and bolts of the certificate, what makes up the components of that for a student, what it looks like across their pharmacy degree. You could see how this could be applied across many different degrees and different health disciplines. So for us, pharmacy school is 4 years, and you don't have to have an undergrad degree, although 80% of our students do before they come into the pharmacy program. And so when we refer to PY1, that's first year. So PY1, 2, 3, and 4. So just think of that as the 4 years of pharmacy school. We begin recruiting or sort of marketing the Rural Scholar Program to the students during their PY1 year. So we let them get on the campus, get settled in, get into the pharmacy school, because that's a big adjustment going from undergrad into a professional program. But then we recruit them and they apply to participate in the program during that year. They don't actually begin coursework in the certificate program though until the fall of their PY2 year, so their second year. And so you'll see on the slide it says seminar PY2 year. So as a part of the certificate, there are seminars each semester, so fall, spring. They are 1.5 credit hours each, and they are actually together in a cohort in class. And here are some of the topics that we cover. Of course, in that fall, it's just an intro to rural health. It's an intro to rural in North Carolina. It's an intro to rural in the country. It's an introduction to social determinants of health and health disparities, just kind of grounding them in things that they've not been exposed to before, because again, they're brand new to pharmacy school, brand new to healthcare. And then the second course, which is in that spring, we call it cultural responsiveness and rural health. And the reason we say cultural responsiveness is because the demographics of rural communities across this nation, this country, this state are dramatically changing. And so to say someone's culturally competent, that means they're, I don't know. I just think culture is changing. And so you should always be seeking how I'm a more responsive healthcare provider to things that are changing in my community. They really love that course. We do some fun things here in Western North Carolina. There's this tour called Hood Huggers Tour, and it's the genius of an African-American gentleman who grew up here and recognized that there was no there was no tourist focus on the African American community that had been at one time small but a very thriving community here in Western North Carolina. And so he has created this Afro tourism out of that, and he always does a fantastic job with my learners in terms of sharing experiences being a Black man growing up in Western North Carolina. If you don't know this, 90% of the population in Western North Carolina is Caucasian. So if you are of a different ethnic or racial background, you definitely feel different in Western North Carolina. And it really is a great space for the students to explore that and talk with him. And he challenges them, like, what are you going to do? How are you going to change this? The seminar during their PY3 year, their third year, they get to do some interprofessional experiences with med students and dental students that are also located here in Western North Carolina. We have a UNC Health Sciences campus at Mayheck. Tell you a little more about that in a later slide, but just know that pharmacy are not the only UNC students here in Western North Carolina learning and training. There's also a public health program, which is a shared program with UNC Gillings and UNCA. And then that final seminar course is population health management, but it's really looking at it through the lens of kind of in your own backyard. So what is population health in a rural setting? What is population health county by county? What is population health town by town? So looking at that data as it rolls up, and then how does public health contribute? How does hospitals contribute? How do grassroots and community organizations play a role? So those are the things that are kind of happening in a classroom setting traditionally. And then on the right-hand side, these are the things that I kind of call that are a little more externally facing, meaning the students have to go out and seek things on their own and be self-directed. So to be a part of the Scholar program, they're required to do community service each semester, 10 hours of that in a whole host of ways. They can do it with their student orgs. They can do it through local small government organizations. They can go to a Board of Health meeting, all types of things. They have a continuity site. I'm going to show you some pictures of those. Basically, that is a longitudinal relationship they maintain with a site that predominantly serves rural patients and a pharmacist over the course of 3 years. So it's a really great way for them to see firsthand how someone cares for patients from rural places. They have a research project, or what I might call, sometimes it's a quality improvement project that they're also doing, again, in that continuity site, so that they have a poster at the end of it, kind of a capstone. And then experiential, of course, we're pharmacists, so we've got a lot of experiential training. So some of their early rural experiences, one of those at least has to be a rural emphasis or rural place. And then for their fourth year, they have to have at least 3 of their 9 experiential placements have a rural emphasis or rural place. So we're really touching the whole continuum of the PharmD student, in the classroom, in the community, in experiential training, to give them a taste of what it's like to be a provider for rural patients in small communities. So one big thing that I think is awesome is out of this, there's about a little above 400 hours of community service almost every single year that is being given, back to the community by our students. So I think that's just a great thing to point out. Here's some photos of some fun, community events and students proudly holding up their educational materials that they developed for one of their outreach events. And like I mentioned, I work really hard to try to connect them to things that are very different than just traditional pharmacy schools. So learning about community health needs assessments. I saw that that's another, I think that's actually later today at 4 o'clock, community health needs assessment work, how that gets done across counties in the state of North Carolina. So I encourage my students, go to a community health improvement meeting, go to a Board of Health meeting, introduce them to people that are working in that space, because I want them to be pharmacists who seek out the people in their communities who are working around community health improvement, and that not be a foreign concept. So I mentioned some of these continuity sites, and I love showing these pictures because 3 of these just look like houses. Now one looks like a really big house, but Mayheck at Cane Creek was literally a home, and they converted it into a clinic. It sits on the Henderson-Buncombe County line, and it's out in this beautiful valley that is very rural out in Cane Creek. There's Mayheck at Woodfin, which is actually close to downtown Asheville and Weaverville, but they have a really wonderful footprint of serving a lot of our Latinx community and Hispanic population. And so that's just a great training site because, again, if you look at the footprint of what's happening with demographics in rural Eastern North Carolina, we have a great influence of Hispanic and Latinx community. Bakersville Health Center up in Mitchell County, the McDowell Hospital down in McDowell County, and then the Hot Springs Health Program up in Madison County. Again, these are all rural counties that surround Buncombe and wonderful places for our students to train. Additionally, we do have med students that also go into these sites, and then the dental students go down to Polk County, and then they're here locally in Asheville. So I'm never really great at graphics. That's one of my dreams this year is to take some kind of graphic design course, but I can talk you through this really easily. So as we think about the Rural Pharmacy Health Initiative overall, one of the things we recognize as a pharmacy school is we need to plant the seed of curiosity about pharmacy school when students are younger. So middle and high school, just exposing them to health careers. So we work a lot with MAHEC around that type of thing. We also are forming relationships with regional universities that are part of the UNC system that don't have pharmacy campuses, which they don't. We're the only public pharmacy school in the state. So we've just put into place some assured admissions programs with App State. We're putting one into place with UNC Asheville. We're putting one into place with UNC Wilmington, recognizing that an outstanding number of high quality students are going to our regional universities, and those are the folks that are more likely to remain in rural communities and serve those communities. And then, of course, figuring out doing internships so that people can get some exposure. All that with the dream of getting them into pharmacy school and then having some of them participate as rural pharmacy health scholars. Not everybody, but the ones that have the interest and the desire. And then we look at things through the lens of what are the other focused training opportunities. So working in interprofessional teams, being connected to community independent pharmacy owners who are really doing a lot to advance practice right now in our state and country. Understanding telehealth, it is the way of the future, and we have gotten a big taste of that during the pandemic. Recognizing geriatrics is here to stay. You know, the silver tsunami is here. Our rural residents look older, much higher rates of folks over the age of 65. And then don't forget our small and rural hospitals, also known as critical access hospitals. Those centers need to be supported regularly because that is still the backbone of healthcare for a lot of our small communities. And then ultimately it's, let's hope we're improving, or, you know, let's look at how are we improving quality and equity around rural healthcare, that we are creating pharmacy leaders that are civically minded and understand their, you know, to whom much is given, much is expected, and they give back to their communities. And that we're seeing a growth in our interprofessional models of healthcare. And then across the bottom of all that, we are seeking out ways to have collaborative research opportunities to share the story of this and understand how we replicate this type of work. And then here's the fun stuff. You know, it's fun. You know, it's always great to look at slides, but it's more fun, I think, to look at pictures of actual things in action. So in the upper right-hand corner, this is one of our very first trips as a group of interprofessional faculty where we went to the National Rural Health Association meeting and shared a little bit about the story of what we were doing here in Western North Carolina. The center photo is a group of students from medicine and pharmacy who had just finished practicing a disaster drill with Buncombe County. Green Shepherd did a nice, I think, web article about that work that we've done in that space. So look for that one on the community engagement site. The upper left-hand corner, it's always the med students that play with the markers, but this is one of our interprofessional sessions that we held with those learners so that they could learn with, from, and about each other. That's another one of those with the masks. That was this year in the masks. And then down in the left-hand corner, and this is actually on Green Shepherd's site, I just looked at it, he used the same photo. Our students were immediately able to get involved in COVID response efforts here in Western North Carolina because of our community engagement work with local Buncombe County health system. Buncombe County, sorry, Health and Human Services. So again, highlighting a little bit of that. So talking about some of those stakeholder engagement wins that we feel like we have had as a campus, and this is just two of many, but the disaster preparedness training, it's been going for over 5 years. we are hopeful that we will reignite it now that COVID is wrapping up. We did our last training January of 2020. Whenever the pandemic began, we were like, oh, what's happening with the virus in China? 2 weeks later, we knew what was happening with the virus in China. But again, it's working with local and state officials. The regional emergency preparedness folks actually come and join us. We use a gymnasium at a local church. So a lot of people, you're like, hey, can we use the gym for free? The win was that our students were immediately engaged in COVID response. We were not able to do this as effectively in Chapel Hill. You know, again, sometimes when you're smaller, you can be more nimble and the relationships are there. And so our students were doing shots and testing and all types of things all throughout COVID. We used to have a community garden. The practice actually recently moved. So we've got to think about where might we put a new community garden, but we used to help support a community garden at a local primary care site. So thinking about food insecurity and opportunities to have fresh produce at a food pantry versus all the packaged and sometimes heavily salted and heavily sugary stuff, unfortunately. So those are some of the fun things that our learners and faculty engage in. And then people are always curious. They're like, so what? Where are they? What are they doing? All right, so this is my attempt with a little road mapping. We'll see, you know, if you can follow along. But going all the way back to our first graduates that graduated in 2017, there were 2 scholars. We retained both of those to live and work here in Western North Carolina. And both of them are serving predominantly rural populations, although not all rural, but predominantly rural. Fast forward to 2018, we had 6 graduates. We have 1 in rural Texas, 1 in rural Wisconsin, 1 at the Durham VA. So I always tell her, you're still serving rural people because they come from all over Eastern North Carolina. And then 3 of them here in rural Western North Carolina, 1 of which just returned after 2 years of kind of her post-grad residency training. And she was thrilled to get back home and back in Western North Carolina. 2019, we had 4. I had 1 graduate. He told me when he interviewed, he wanted to go back to Alaska and work with Indian Health Service. And so his dream came true. That's where he is in Juneau. 1 working out in Idaho as a telehealth pharmacist for rural VA patients. 1 in Winston-Salem, 1 in Chapel Hill. 2020, 1 way upstate in rural Michigan, 1 in Chapel Hill, Nashville, and then 3, again, back here in Western North Carolina, serving communities. And then our 2021 class of 9, that was a lot of them, they're in what I call the year 2 residency training reshuffle. So right now, they're kind of saying, what am I going to do? Am I going to go into year 2 of residency training? Am I going to seek a job? So I'm keeping my eyes on them to find out where they're going to land. And then I do have details. We just had match week last week, and I had a class of 4 for class of 2022. All 4 of them have matched in sites that are going to serve predominantly rural communities. Unfortunately, they're all going all over the country, and this is one of the things that I'm learning about this program, and I have seen this in medicine programs as well. We can do things in the core curriculum that influence a lot of choice about postgrad training and thinking about postgrad training, but ultimately they're going to go away probably for that training because we don't have enough residencies in North Carolina to serve all the people, you know, who are seeking residency. And students are also looking to diversify themselves. So they want to go to another program to get clinical training because, again, it helps diversify who they are, gets them credentialed in different ways. What I am pleased to see is the drifting back of people after that post-grad experience. So I've got a lot of years of data, I think, to continue to collect. The results look promising, at least, that if they don't return to North Carolina, they're still very mindful of serving rural populations. So that's part of the story that we're trying to, you know, understand a bit more. There's not a lot in literature about this as it relates to pharmacy. There's a lot more in medicine. And so we are working with our medicine colleagues to say, well, how will this play out, you know, for our program? So talking about what I call continued opportunities, successes, I could say challenges. Like, it was kind of funny. This slide 3 years ago was my challenges slide. And so I've converted the heading because I've actually, in reflecting on this, been able to make some good strides with this work. So one of the things I noted is that I still wasn't able to get students deeper into rural communities 3 years ago. And that's because when you're developing a program like this, you also need to be developing preceptors and forming relationships with preceptors in places that perhaps you haven't sent students in the past because you didn't have housing or you didn't have a rural health program. So what we have now seen is that our learners, I just got the list of my fourth years that are getting ready to go on rotation. And I was so excited at the number of rural placements that they have and that they are further away from sort of our campus here in Asheville. So I felt like, wow, checkbox, we're making progress there. We're seeing the development of the footprint of our relationship as a school with preceptors and then for our students' experiences. Again, creating and sustaining those opportunities in Far West and Far Eastern. So I mentioned that I'm making some strides with Far Western, and we are in the early conversations of how will we replicate this in Eastern North Carolina. So one of our goals is for 2024. We will be looking at least to put students more strategically into rural settings for experiential and then get the full certificate up and launched across our entire school. I think probably COVID helped us realize we could really do this because we can do so much of our training in a virtual environment and still be successful. And then if you didn't know, Murphy to Manteo is 545 miles. There's a lot of state to cover for North Carolina. Optimizing UNC Health Sciences at MAHEC, which is the entity that is the med school, the farm school, the public health school, the dental school, also collaborates with Western Carolina, this footprint of healthcare training here in Western North Carolina. And then opportunities around interprofessional education and practice. So I'll show you this. I've collaborated quite a bit with Meg Zamarati's office in terms of the work that they're doing on UNC campus as it pertains to the Distinguished Interprofessional Education Scholars Program. And we wanted to make sure that our health sciences at MAHEC students also had opportunities when they're here to contribute and participate in that. So we've developed our interprofessional collaboration tagline and are building curriculum around that. And I share a 2-day-a-week appointment with MAHEC working on that work in the intersection of rural health. All right, so this is a busy slide, and all I want you to take away from this are some highlights of why it is so important that we have well-trained pharmacists in rural communities in the state of North Carolina and across the nation. But this is a House bill that just passed this year, House Bill 96, actually back in the fall, I think, of 2021. Just last week, the standing orders associated with pharmacists being able to prescribe oral contraceptives were written and approved. And basically what that means is that's one of those gaps in healthcare disparity. So you won't find equitable access to contraception, obstetric gynecologic care for that type of thing in rural communities. And some women would have to travel, pretty far distances unless they had a family practice provider who could do that prescribing. But now they can go into their pharmacy through protocol if they're a healthy, within the parameters of our prescribing protocol, young woman, they'll be able to meet with a pharmacist, get their prescriptions for oral contraceptives and get that filled in their own community. And so that's very exciting. And then along with that are things doing more with nicotine replacement therapy, being able to administer long-acting injectables for antipsychotic medications, if you can imagine the gap as it relates to mental health care, and folks who are trying to maintain their health in that space, having to travel an hour and a half to get their injection. Now they'll be able to get it in their pharmacies that, decide to pursue that. So again, it's pharmacists working in collaboration with public health and primary care to say, how do we extend care into communities where there are gaps in that care? And so this House bill is one of those really, I think, steps forward. I think that COVID helped really bring to light the power of pharmacists in the space of public health. And I hope that that work will continue, because I do think pharmacists are one of the most accessible healthcare providers in a community. And there are more ways to contact and work with that pharmacist beyond just picking up your prescription in their pharmacy. So my closing slide is a question. And for anyone who listens to this or watches this later, I'd love to hear from you in terms of the where do we go from here? Where do you see opportunities for us to collaborate across the university in ways I haven't thought about? If you just have a question to follow up with me, I'm Stephanie Kaiser, Kiser. That I'm sure that'll be posted on the website as well. There is another Stephanie Kaiser, but I'm the one at the pharmacy school. So, and for whatever reason, the other one doesn't send me my emails if it goes to her. So it's great sharing this work with you. I hope you can see I love it. It's a lot of fun. Working with students is delightful. And I really think more programs like this are needed to help assure our commitment to the state. So thanks for your time today. Questions? Ryan, go ahead.
I do have a question. I raised my hand even though maybe that was unnecessary. Thank you for the presentation and the overview. One of the things I'm thinking about from a programmatic perspective is what the students' motivations and incentives are for participating, and if they stick with it, if the numbers you outlined are who started in the program, or if some people sort of sign up and start and keep and kind of drop off at some point when other demands hit them. Leave the question there. I might have some follow-up.
Yeah, no, those are great questions. So motivations and incentives. So one of the things, I don't have huge financial incentives for students. Actually, they can, once they become a rural scholar, they have an opportunity to later apply for some scholarship in terms of, because they're doing rural emphasis, but they don't get, you know, any cash actually to enroll and participate in the certificate program. It's one of the things we'd like to pursue, is to try to find donors that are really passionate about rural care and pharmacy and align those learners with those donors over time. But mostly what I see as motivations of students is they really get that connection of healthcare disparity and serving underserved populations. So when I interview and talk to these students, there's always that sort of passion of, I want to give back. I see where, you know, certain individuals aren't receiving the same care or equitable care, and I want to be a part of that. I think this generation of learners is very much about, how can I give back or make a difference? Additionally, some of them come from rural small places, but not all of them. So I can't say, oh, they're all from rural small places. That's not the case. I have at least 3 of them that grew up in urban cities, but have ultimately ended up practicing in more rural places. I think what you find is there's been some life experience or person that has had a rural influence on them. I can think of one who, he had a global experience in a really resource limited place, and just kind of got that passion of like, I want to work in places where I'm filling in the gaps around resource limits. So I'd say passion for the underserved, some influence of rural through family or other experience, you know, grandparents that lived in a rural place, that type of thing. And then just that motivation to give back. I'd say those are the 3 big things. And then in terms of who sticks with it, so far I've had 100% graduation rate in terms of the Rural Scholar Program. Granted, that could always, you know, change over time, but in terms of the graduates all the way up to 2022, the 4 that are about to graduate have all completed their requirements. And so that's very encouraging as well, because it is extra, but I think it's a testament to the fact that what we are offering to them through the certificate program is seen as an enhancement to their current PharmD education. They see it as beneficial. They can find a place to apply it that's, you know, it's relevant. And so I think that makes a difference in that space.
Stephanie, I have a question that is a little bit related. I'm interested in what you said about the global context and how rural communities can be everywhere. And we also know every single community is different. Do you see parallels around rural issues, and do students kind of study rural community issues beyond North Carolina and within North Carolina. I was especially curious that you had folks who wanted to go to rural communities and went to rural communities in other states as well.
Yeah, we touch on it. I'll say that largely the curriculum that I focus on here in Western North Carolina is, through a North Carolina lens. But when you talk about social determinants of health, it's so easy to apply that across, all spaces and locations. And to your point, one of the things, I have a colleague, he just recently left UNC Asheville School of Pharmacy, but we had a course that we ran together, which was, global and rural, because we recognize that intersection of there are skills you need when you are working or trying to impact health in resource limited places that are very similar. And so it's just about the understanding of how you navigate relationship, communication, project planning, quality improvement. So, we also kind of called it sort of public health 101, blended in, but we do it through a tabletop rural health topic, while also having them look at the global health goals as it relates to health and say, well, how does this actually connect to global health? Because actually chronic conditions are the fastest growing disease burden across the globe. It's not malaria, it's diabetes. So really helping them see that and understand that. And so I actually have several rural scholars who also will go and have global experiences during their 4th year. And it's been a really good fit for them to do that. I hope that kind of answers.
I really appreciated your presentation and think it's interesting. And I loved how you talked about cultural responsiveness rather than cultural competency. And sometimes we use the term cultural humility when we're talking about those issues. And so I especially appreciated what you said about that, but great presentation. Thank you.
Thank you for being here. And thank you again. And if you haven't, if anybody listens to the recording, just reach out. I'm always open for new ideas. And you guys have a great afternoon.